Nick Majerison here, and welcome to Top Med Talk. It's a conference highlight, presented by Monty, Mythen and Mike Grocott with their guests, Joel Symmons, staff consultant anaesthetist in the Department of Anaesthesia and Perioperative Medicine at the Alfred Hospital, Perioperative Medicine short course convener and a senior lecturer in Anaesthesia at Monash University, and Paul Myles, head of Alfred Health's Monash University's Department of Anaesthesia and Perioperative Medicine. It's a short enticement to listen to the fuller conversation, which I'll tell you about right after we listen to this clip.
What David Walker and I have realised over the last few years is that different institutions approach perioperative medicine from very different angles. The angle that UCL has approached their perioperative masters is different from that of Monash. And what we realise is that we actually really need a hybrid of both of those curricula to develop a true perioperative medicine curriculum.
Excellent. And there is a global audience, I think, for that. And there are, as you say, other master's programs that have been launched. And, the ambition is to get the education as broad-based as possible. Now, masters are, in some people's view, relatively expensive. They're extremely high value for money, but not necessarily accessible to the whole world. If we're working in the Australian economy or the UK economy, which broadly speaking is similar to many of the economies you've referred to, that's not really going to open it up to the whole world. Is there any way that we can make the learning more accessible? I'm not sure we can change the economics of getting the degrees from our universities, but can we make the knowledge base more accessible?
Yes, I definitely think we can. We need to develop courses which are more economically accessible to the majority of the population, and that could be done under a structure like an international board for perioperative medicine, which would not only make education accessible, but would also ensure that what is being taught in perioperative medicine is similar throughout all regions of the world.
Now, one of the risks there is we label it in some way and it becomes an international diploma, certificate, whatever it is, and then the suggestion is that somebody does a version of that in a relatively uncontrolled way and says they're now a qualified practitioner. So how do we keep a lid on that?
We'd have to be very careful with that and pitch it more at a level for education acquisition in perioperative medicine. Differently from what Mike had said with what your college has done, the College of Anaesthetists in Australia is actually of the view our training is 2 years shorter than yours, and we didn't feel that our trainees had all the skills to be called perioperative medicine specialists. So what our college is doing is having a two-tiered system where people who have their anaesthetic fellowship from our college will be called perioperative practitioners, and then there will be a 2-year fellowship which is optional, which can be done to get a formal perioperative medicine fellowship, and those people would be called perioperative medicine specialists. And our college is working on that at the moment, and we should have a fellowship in the next 4 to 5 years.
Fantastic. So, Mike, the way you described what we have now of people who are going to get the FRCA, become a fellow of the Royal College of Anaesthetists, that is or isn't the plan?
So it is the plan, and I'm
not extending training. We think
we don't think it will extend training
because we're 2 years longer already.
There are folk that could do. Some people are already choosing to do perioperative medicine fellowships, and therefore clearly mark themselves out as someone who's going to be leading a service, and this will be a major part of their career. And this isn't really an educationalist comment, it's more how the profession develops. We took the view, and certainly I hold the view, that if you start to divide people into those that do and those that don't, the path feels like it leads to schism. So in the same way as we've seen in critical care, where you get a faculty and then the faculty develops a momentum of its own and naturally becomes an independent specialty, and you're probably 20 years further down the road in Australia than we are in that regard in the UK, that carries great risk for anaesthesia, in my view, as a profession. And actually, the alternative route is to say we're all anaesthetists and perioperative physicians, and in a way that guards against the the risk of what's coming, which is non-physician anaesthesia providers and technology, which will eat up some of the technological role of anaesthetists.
But it sounds like we're going to end up in the same place, though, Mike. People who get their FRCA without extending their training will be perioperative practitioners.
Correct.
The people who decide to do a fellowship en route and do the advanced training will be the specialists, as Joel just described. Is that?
So we'll end up in the same place in that regard, but the people who don't do that in Australia in 30 years' time may find themselves more professionally vulnerable than those that do.
Did you see it that way, Paul?
Well, I think those concerns are real, and I think this is part of the conversation everybody should be having around the world, certainly anaesthetists or anaesthesiologists, because we need to get a better sense of where our future lies as a profession, and it probably lies in a range of directions. And I think there is room for that flexibility, but without it being in any way restrictive or damaging or creating a schism in the process. I think the important part of it is for everybody to continue the conversation so that we're aware of where we're going, what are the risks and benefits of it, how can we justify certain decisions. And I think if we are engaged in the process, we can obviously help steer it in the right directions, focusing around what's best for patient care and so on. And I think the future will be fine. If in fact, after several years we feel that there are some issues that are arising that we hadn't foreseen, then I think we can always change course again. We can always make adjustments to what we're trying to achieve.
I think what we have to be mindful of is that we've looked at all of this through a slightly different prism. Because I think, Paul, you referred to it yesterday, you did some other things in medicine before you took a side entrance into anaesthesia. Is that right?
At least in part, yes.
and Mike, I think you're what the Americans would call triple boarded. Is that right?
So I also did some other things, both medical and non-medical, before getting into anaesthesia.
I did 4 or 5 years of general medical and specialist medical things. So we actually had quite a lot of general medical training, which makes us slightly lose sight of the fact that you might need those few extra years. And in the USA, when I was working there, if you did subspecialist anaesthesia training, it's a 3-year program that flash to bang, and does not include much of that general medical training. So that's what you're addressing in your plans, Joel, is that right?
Correct. The Australian and New Zealand College of Anaesthetists is of the view that we don't own perioperative medicine, and we are modelling perioperative medicine on our Faculty of Pain Medicine, where the college is just really an umbrella body for a whole lot of other professional organisations like the College of Physicians or the College of Surgeons. So the aim of the College of Anaesthetists is to really oversee perioperative medicine education and qualifications, but people will be able to come into perioperative medicine from numerous directions.
So you're on course to have a new faculty?
No, we're not developing a faculty at this stage, just a fellowship. The College Council stopped short of developing a faculty at this moment in time, but that might change in the future.
Where do you think we are on that one, Mike?
So I think our ambition is similar in that we hope to be the home of perioperative medicine within medicine more broadly. So if you were a surgeon or a primary care specialist and you wanted to do that, you would come to us, to the Royal College of Anaesthetists, to be credentialed and probably have associate membership. But our current view, I think, certainly my personal view, is that all anaesthetists should have that training as part of their core training. So you would become an anaesthetist and perioperative physician.
Over the horizon, because the discussion at the Royal College of Anaesthetists started before we got there, including discussions about a potential name change or at least a strapline change. Now, if the majority of departments around the world, like yours is, Paul, and ours is, and I don't know what yours is, Mike, ends up being called Anaesthesia and Perioperative Medicine, does the college eventually follow that path? Or the colleges follow that path, or is it irrelevant, like you said yesterday about the London School of Economics?
No, I think it is relevant. I think it's important. I think if we don't, we risk others choosing to declare that actually that they are the home of perioperative medicine, and I think that would be a great shame for our specialty and probably the wrong thing to happen overall for medicine. I think the timing, I think there's a lot of support, certainly in the UK at the moment, from our surgical colleagues. I think they understand the need for this. And the comment about London School of Economics was you don't lose your core brand by adding additional brands. So the London School of Economics is actually called the London School of Economics and Political Science, but we all know it as the LSE.
So the Royal College of Anaesthetists and Perioperative Medicine might be what it's called in the future, but people don't stop calling it the Royal College of Anaesthetists.
And most of the time we call it the college, or
exactly, or the RCoA. Paul,
and I think also, of course, I would never stop calling myself an anaesthetist. I'm very proud of our specialty.
Yeah.
Absolutely.
I've always believed, really from day one, that the very best anaesthetists or anaesthesiologists are good doctors first of all. I mean, the technical skills and the application of anaesthesia for the surgical patient is crucially important, highly complex, and requires a lot of training. But equally, we are also doctors in the more general sense, and with that we need to integrate patients' comorbidity and risk of complications and all the rest of it that goes into what we now think of as perioperative medicine is, I think, a key components of a good anaesthetist. So I've been listening to what Mike's been saying around, I guess, the core training really of the specialty, and how perioperative medicine is an essential large part of that.
Top Med Talk.
Tell us your thoughts on this. Contact at topmedtalk.com. And don't forget, the longer piece is called RCoA 14. How should we teach perioperative medicine? You can find that on the website topmedtalk.com. And don't forget, you can meet the Top Med Talk team. All you need to do is turn up at one of our events. Check out ebpom.org for more details. Our next big event is EBPOM 2018, the London Perioperative Medicine Congress. That's at the Institute of Engineering and Technology between the 4th and the 6th of July. Check out the website for more details, ebpom.org.